Good afternoon, everyone. My name is Luisa Borrell. I'm a faculty in the Department of Epidemiology and Biostatistics, and it is my pleasure to introduce you to Dr. Javier Padilla. He is the Secretary of Health in Spain, and he's a physician with a degree in public health policy and management, and health economics and drugs economics. And what Javier is unique is that he has been able not only to merge clinical work with population health, but he has also bring to it this social justice aspect. And he's the author of several books that we were talking about the fact that they should be in English so people can benefit or the information and the intertwined framework that he used in the context of health outcome and social determinants of health. For example, the book that was written during the COVID pandemic, Epidemiology, is sort of bring together the social class and how the social position of individual put people at risk, and how that sort of trickle down into who got affected with COVID and who was the most vulnerable. The other book is about Mal Estamos, so in English, We Are All Bad. It's about bringing attention to mental health and how this is a collective issue. It's not about me being depressed, it's about how that affects the community as a whole. So without further ado, I will introduce you to Javier, and at the end, we probably will have a lot of questions for you. Thank you.
All right. Well, thank you very much, Luisa, and thank you all for coming. Okay, perfect. Thank you very much.
Your Excellency, I will just ask you to remain close to the mic.
Yeah. Perfect. And well, hello to the people who are also online. Well, first of all, I would like to start by talking about what I'm going to say. I'm currently at a political position. I'm the Secretary of State for Health in Spain. I'm the equivalent of Under Minister, and I think that the public health framework is the most useful framework to work not just on health policy, but in politics in general. I think there is no such a framework as the public health one, with this capability of merging many different views and many different ideas that are really close to communities and that are really useful for the exercise of politics. Okay. Well, first of all, I would like to say I'm going to talk about how we try to, in Spain, how we try to develop our domestic policies with a view of global health. So that global health policies and domestic health policies should be something coherent, and it's not always like that. In many situations, global health policies are very different because they are involved external affairs ministries, but in domestic health policies are a matter for ministries of health. So our starting point is this one. So we try to develop health policies starting by the point that health is a matter of justice. And when we are talking about health, we should be talking about social determinants of health, about the fact of the existence of the inverse care law, as Julia and Tudor Hart established that in general the healthcare system tends to provide a high degree of attention to the patients that need less, and the less attention to the patients that need it the most. And also for the reflection that its health is a matter of justice, then we cannot, as political leaders, put the responsibility of health outcomes on individual behaviors, but we should also accomplish the importance of the social determinants of health. And this last sentence, the importance of what, who, and how. Luisa was saying before that I have the Master on Public Health. The dissertation I did with my Master on Public Health was about theories of justice. Theory of justice is the field of political philosophy that talks about how justice is built in societies, and every theory of justice has to answer three questions. What are we going to distribute, how we are going to distribute that, and for who and to whom we are going to distribute that. So when we are talking about health as a justice issue, we are going to talk about what we are going to distribute in healthcare on different provisions, who are going to distribute that for, and how are we going to do that. So we are trying to look at the global health through the peephole of domestic health. I want to take advantage that the people that just entered are taking, we have brought from Spain some leaflets from our Spanish global health strategy that we just published. We are not very used to translate into English, but as we are talking about global health, it was especially significant to be able to do that. So, in my opinion, we have, I wanted to outline three global, and I think that shared all around the world, three global challenges for health policies when we are talking from a global perspective. The first one, and I think that it might be the greatest challenge, not just for health policies, but also for global policies, is the matter of universalism. I think that universalism should be thought not just as a matter of effectiveness of policies, not just as a matter of efficiency of policies, but also as the need to legitimate the policies that we are trying to implement. So universalism would be like the first challenge for health policies nowadays. The second one would be the new geopolitical balances. I think that we tend to analyze global health as a global north who is providing assistance to a global south. It's not going to happen anymore. There is nothing called global north in general. We are seeing how many important actors are all around the world, like India, China, Brazil, Argentina, or even also South Africa, especially, are also struggling with the status quo in matters like trade or like intellectual property that have a very important effect on global policies. So I think that these new geopolitical balances are going to impact on the future of global health. And the third one is about how we try to increase the health policies in general and specifically the public healthcare systems in times where everything is contracting and not expanding when we talk about public services. So it's very easy for countries with strong national health services to say that this is the way. So if you live in, I don't know, in UK, or if you live in Spain, or if you live even in the Netherlands or in Germany, countries that after Second World War started to build national systems that now they are struggling, but they have like the structure. But how do you get to have this structure in many countries in a time that building this structure is not even seen as a possibility for this government? So I think that this is like the third big challenge that we are facing. So I want to develop my lecture by using the 6 strategic points that we have been developing in our Spanish global health strategy. The main points of the strategy is to try to align the global and domestic policies with a perspective of social justice, also trying to take the global health debates, trying to import in the global health debate some of the issues that are not so common, but are also very important. I'm talking about the workforce crisis, which is global, but I'm also talking about the biomedical innovation model, everything related to intellectual property and so on. And also that in times of global health weakness, we should to think about what are we going to oppose to this global health weakness in terms to beat this situation. As Baruch Spinoza, the philosopher, said, we need a bigger potential in the opposite direction in order to overwhelm that. So these are the three main strategic objectives that we have in our global health strategy. And I have tried to outline three specific issues that I think that they are specifically important when talking about global health policies. The first one is strengthening the public health systems. For us, if we are talking about strong public health systems, we should be talking about universal health coverage. We know that universal health coverage is very different depending where you are talking about universal health coverage, and that universal health coverage should not be seen just as a right, but just the entitlement, but also the actual access to the health coverage. But if we want to resume to a very simple purpose, a very simple objective, we should say that the economic barrier should not be a limit for the access to universal health. As Michael Marmot was publishing some years ago, we should also go further and not be thinking just about universal healthcare access, but also about universal access to social determinants of health. So integrating social determinants of health in our UHC perspective. The second one is that we are not going to be able to have a strong public health systems if we don't have a strong primary health care. But also that we might have quite a good health system without primary health care, but it's not going to have an equity-based approach. So primary health care is the possibility condition for equitable health systems, especially if you are trying to build these health systems from the ground, not if you already have this already built. And the third thing is about the healthcare workforce. When every country talk about the health workforce crisis, everyone makes it from a very selfish perspective. Everyone says that they are lacking physicians, they are lacking nurses, they are lacking a different kind of professionals. But the thing is that we are facing a global issue, and that this global issue is impacting especially lower income countries. 1 year ago, I was attending a meeting in Washington that was held together, was hosted together by PAHO and by WHO Euro. We were going as a country who were receiving many healthcare professionals from different countries, but there were some countries, especially in the Caribbean, that they were suffering the migration of the 30% of their nurses in the last 3 years. So there is not a normal system that can really afford this rate of renewing their workforce. So this is especially important. But something that is especially important is this one. Not just the amount of professionals, but at a global perspective, the role of a specific group of professionals that are the nurses. I think that the future of healthcare systems is going to be represented by our capability to convert, to make that nurses become like the core, the nuclear professionals all around the health system. And the third one is about when we are talking from a global health perspective about healthcare workforce, we should be talking about ethic healthcare workforce recruitment. Higher income countries have a responsibility on the situation on middle and lower income countries healthcare workforce. And this is something that we should be knowing about. In Spain, for instance, everybody is very aware that every year 800 doctors are migrating to other countries, but we are receiving 8,000 doctors. So we are receiving 10 times the doctors that we are sending to another countries. Doing that from an ethic perspective, and I think that this is something that is being worked from at a WHO level, is something very specific and very important for this situation. The second thing is the second strategic line from our strategy is about health promotion and equity-based approach. I think that global health should not be seen, and we will talk about that after that in this session, should not be seen as just assistantialism, and should be seen as a way of promoting a way of practicing public health all around the world, especially with the social determinants of health, the commercial determinants of health, and the need of having upstream interventions as a way of promoting health, but also trying to, and this is our perspective as the Spanish perspective of global health, we should be facing the situation that sexual rights and gender equity approach is not as easy all around the world, but having a respectful approach should not be seen as removing the approach and the need of talking about sexual rights when talking about global health. This is something that has been really controversial in the last years, especially at the multilateral organizations, many resolutions that have been removing everything related to gender equality or LGBT rights and so on. And from our perspective, this is something that we should not be renouncing to, and this is very important also. And the third thing would be at the chronic conditions and the role of prevention. And we are working on chronic conditions in the end of all the ethiopathogenic tail. We are a story. We are not going to be able to do that in efficient conditions. So we should be talking about how all these interventions that are like multi-disease intervention that are going to have effect on very different diseases are going to be like the core intervention we are going to do at a global level. The third thing would be about climate change and health effects. I think that 1 decade ago, maybe a global health strategy would not be talking about climate change, but I think that now in 2025, we cannot be talking about global health without talking about climate change. Building resilient and sustainable health system is something that maybe we didn't when we built our systems, but should not be overseen when building new health systems. I think the One Health approach, that is something that is in all the in all the conference, all the events, but not is really done in all the policies. It's also something that we should do specifically, as we have been seeing in the last 2 decades, the increase of the zoonotic diseases as a global health threat with a pandemic potential. And also the third thing would be the need of coordinating in adapting healthcare system to climate change. When we are talking about climate change, we tend to think about the increase of the temperature or of the adverse effects, but we should be also trying to think about how we are going to coordinate the different systems in order to tackle these environmental catastrophes like drownings or earthquake or similar things that are more common every year are also a public health threat. The fourth thing would be about prevention, preparedness, and response for public health emergencies. I think this is something that has been in the top priority after the COVID-19 pandemic. I think the first thing would be like support global preparedness for public health emergencies. The second thing would be talking about how we need a global surveillance system and the pandemic governance. I think that you are aware that last May, the pandemic agreement was signed, but all the countries who were attending the World Health Assembly without the involvement of the United States, and maybe without the involvement and thanks to the absenteeism of the United States, because else we don't know if it would have been like possible. But I think that even though it was not as ambitious as we wanted it to be, the existence of the agreement was also something that, like a milestone, that backed the only existence of the multilateral organizations like WHO. The fifth strategic line was about how to promote a robust global health architecture. And we know that we are facing like a the new global health order. We were talking about before about the existence of different emerging countries, which have a very important role when talking about health, but also because we know that maybe the next pandemics, the technology transfer is not going to be north to south. Maybe some of the transfer is going to be south to north, and it's going to change all the environment of how we are dealing and how we are trying to govern the pandemic situation. I think that the pandemic agreement was a model, but should be like the first step. And it should be also think that we should be increasing the international and the bilateral and multilateral health cooperation. As we in Spain, we have recovered all the programs that during the last decade were eliminated, were removed in terms to increase this kind of cooperation. And the last one, and it's something very important for us, we didn't want to approve a global health strategy that was not talking about research and development. It's not just talking about how we are making that health system around the world have enough healthcare professionals, but it's also to think that what are we going to do in order to innovative drugs, for instance, or diagnosis tests or whatever, is going to arrive to the places that they are needed. So we should think and we should contribute to equitable models for R&D and production. For instance, next month we will be, or in a couple of months, we will be going to Colombia to a CELAC meeting to talk about a program to increase the local capabilities of production of vaccines in Latin America and Caribbean. I think it's also being done in some regions in Africa and especially in southeast of Asia. I think that also we are working at an international level, and I think this is something very important, how we incorporate, how we integrate the public interest in public health emergencies. So if we have been investing for many years in the development of the technology that is going to give us a vaccine, if this investment has been with public money, it's not possible that we are going to pay for that twice. When we invest on that and afterwards when we are buying the final development. And I think that integrating this view is also important. And I think that the best example to understand the importance of R&D, intellectual property, and all that when talking about global health is the situation that we have now with HIV and the pre-exposure prophylaxis, the PrEP. I don't know if you know that, you may know, in the last years, there have been released a couple of drugs, especially one of them, lenacapavir, from the pharma company Gilead, that gets the pre-exposure prophylaxis for HIV to be twice a year, and there are some papers saying that it's going to arrive to be maybe once a year in some months and in some years, instead of being with the daily pill, or the other one, the other long acting is once every 2 months. Well, the thing is that in the countries where the expansion of this drug has the most effect, so the countries where the lenacapavir is a game changer, are the countries where lenacapavir is not very clear it's going to arrive. But the countries where lenacapavir might be available for patients are the countries where the availability of many other different options and the very high rates of indetectability, so it's not transmissible, are very high. So if we don't have the intellectual property conditions in order to be feeding our global health policies, in order to make that innovative drugs meet the patients who need the innovative drugs, these game changers become nothing changers, because it's not going to arrive to the people they need. So I think HIV, as it was 3 decades ago, is the best example to show how intellectual property rights can be like a struggle between the patient rights and the patents rights. At the domestic level, we are also trying to see how we incorporate this long-acting PrEP into our national portfolio, and we are also doing that, showing a deep concern about the global health policies that the companies are having, in order to show them that our national decisions are really influenced by the global health decisions that they are also doing. So this would be like the global perspective. These are like the 6 main strategic lines that we are working at the global level, and I think that it should be like more or less exchangeable between different countries. But how are we doing that at a national level, trying to look by the peephole for the global one? No? So what about Spain? And well, you have seen. Thank you very much, Luisa. And this is the Guernica, maybe the most famous draw in the history of Spanish art. Well, there have been. I wanted to share with you some pills of information about how is our system and how is our situation. I think that when we talk about what is a national health system for, so what are their main functions, there are 3 that we should outline. The first one is it should be useful to improve the health status for population. The second one is that it should be useful to give an answer to the needs of the population and to the demands of the population. And the third one is that it should be useful to protect the economic situation of the individual. So I wanted to show you with these 2 very important documents how is the situation of Spain, in order to afterwards be talking about what are the policies that are going to be aligned with the global ones. These are 2 documents from especially the European Observatory on Health Systems and Policies, that for us are like the Bible when talking about public health, especially public health in Europe. So Spanish health system is complicated to understand, but nothing compared to American one. So especially because we have, even though there is a role for private healthcare, we have kind of a monopoly of the public health system. So the 70% of the total expenditure is public, but the part of the 30% that is private, most of them is for the co-payments for the drugs or for the non-covered provisions as services, like something related to bucodental or the glasses or something like that. But we have a very decentralized system with coordination board with the different regions, and afterward the Ministry of Health, where I am, and the different regional departments. The regional departments are in charge of the provision of health, and the Ministry of Health is in charge of the regulation, but also the coordination between the National Health Service and the biggest part of the pharmaceutical policy, and a very important part of everything related to public health and, well, coordination on transplantation and so on. So we used to say that life expectancy in Spain is very high. We have one of the highest life expectancy in the world, especially for women, but for all the population in general. The thing is that this life expectancy is not so high when we are talking about life expectancy in a healthy way. So in Spain, we have a population living a lot of years, but living with disease or with any kind of handicap a lot of years. And especially if we analyze that by gender, we can see that the amount of years over 65 that are lived with healthy lives are mostly the same between men and women, even though women are living in very big number of years with any kind of disease. No? So we are above the general population in the European Union, but we are not the top performers when we are talking about healthy lifestyle. So in Spain, we live a lot of years, but this year don't have such a big amount of life as we have in the other indicator. When we talk about what are the risk factors that we should attribute the risk, we see that tobacco is the biggest one, and we see that in tobacco we are quite similar to the European Union. It's something to worry about because many of the countries, especially in the eastern countries, have very bad indicators of this level. So Spain, I think that we should aim to be in a better situation. We are struggling also with the new ways of tobacco, the heated tobacco, the e-cigarettes, vaping, and so on. We know that from a dietary risk perspective, we are better off than many other countries, and we are similar in alcohol, air pollution, and the low physical activities. It's been written a lot about why Spain, that has lower socioeconomic situation compared to many other different countries in Europe, has better health indicators compared to these other countries. So we have a lower level of extraction, a lower income, we have worse working conditions than other countries, or at least we had, but our health and our life expectancy and even other indicators is better than this. So it's called the Spanish paradox, and it's one of the things very well studied at the European level. So this is our health spending. We are spending lower than the average in the European Union. Maybe one of the things, it's also because of the kind of system that we have, but also another of the reasons is because at the professional level, the working costs are lower than the others, than the ones we have at other countries. We can see here, the Spanish one is the orange one. So we can see that in Europe in general, as the percentage of the GDP, the 2 first years of the economic crisis of the 2008, there was an increase on the representation of the healthcare expenditure above the amount economy. It was because countries delayed a couple of years the austerity measures in order to constrain their budgets. But I think that in general, the evolution is quite the same in all the countries. Then the pandemic arrived, all the countries increased their budgets. Many of the countries are going back to the situation before the pandemic, but Spain is staying in the same situation as the top in 2020. It's very possible. It's possible that it's because of the that we were living in an under budgetary situation for the times before the pandemics. I told you that one of the purposes of a public health system is to protect the population for catastrophic expenditures. And I think that this is a paper that, well, I think that if we should say one indicator where Spain is a top performer is at protecting their population against budgetary issues related to health. We could say, we see here that in Spain is quite an anecdote to have problems because of health matters related to economic struggling. This is another one, and I think it's very useful because if you are talking about healthcare in general, you are not going to be seeing even an inequality between the poorest quintile and the richest quintile. But if you are going to the dental care, you are going to see how the unmet medical need for dental care is quite higher in the poorest quintile and not in the richest quintile. This is one of the things that we are trying to tackle nowadays in Spain. This is another from another document, just from the observatory, that is saying the same. So Spain is far above the average in unmet medical needs for medical care, but is above the average for unmet medical needs for dental care. The other thing I was saying that was one of the purposes of a public health healthcare system is improving the health of their population. I think that we have one of the lowest rates of avoidable mortality in the European Union. I think that this is something that is something to be proud of and to work to continue. And maybe one of the things that we are struggling all around the world, but we are also struggling in Spain, is everything related to mental health, and especially everything related to the social inequality linked to mental health and linked to working conditions. So when social determinants of health meet the mental health, I think this is something that there is no healthcare system that is able to give an answer from a medical perspective to the global needs of a society from a mental health perspective. But I think that this is something that has been increasing after the pandemic. So we were saying before, what were the three top challenges at a global level? At the domestic level, we have these three top domestic challenges. First one is updating our national health service to 21st century. After the economic crisis of the second decade of this century, it was like a lost decade for our national health service, so we should update. We should widen our national health service, trying to arrive into dental care, trying to arrive into midterm services and so. And the third one is quite abstract, but I think it's really important for us. I don't know if you have seen a TV series that was just released in Netflix. It's called Hostages, and the prime minister. It happens in the United Kingdom, and the prime minister of the United Kingdom there is elected upon a discourse and a proposal of recovering the national health service as people knew it. So in countries where national health service is a part of is a kind of national anthem or something similar, I think that trying to develop from a political point of view the needs, the necessary interventions in order for people to feel it as a cultural value, as a part of their identity, is something very important. I think this is the way of protecting the national health service to be like dismantled when the different political signs are changing. I think that some years ago, it appeared in the UK a political party that was called something like protecting national health service. I think that recovering the pride of the National Health Service in Spain is also one of our needed priorities, because else we are going to lose the level of protection that population gives to the public healthcare policies in their different institutional levels. So when we talk about strengthening the public health systems, we're talking about universalism, and now I'm talking about public healthcare in Spain as the top priority. I think that one of the problems that we have with primary healthcare is that primary healthcare was built trying to give answers to a society that doesn't exist anymore. So in primary healthcare, you have all the available evidence about that having the same doctor for over 15 years is going to decrease your mortality, your attendance to emergency and so. But the thing is that nobody has nothing for more than 15 years now in your life. You don't have the same job, you don't have the same house, you don't have the same couple for more than 15 years. So one of the challenges we are facing is how we update the primary healthcare values to the societies that we are having right now. The second thing I wanted to say is about healthcare workforce. And I wanted to give you this picture. It comes from the Framework for Action on the Healthcare Workforce in the WHO European region, and I think it could be universal, because when we are talking about the scars of healthcare professionals, we tend to talk, and the question is, do we have enough doctors, for instance, or do we have enough nurses? But I think that is the wrong question. The question, for instance, in Spain should be, why in the moment that we have more doctors in our history, we are having a doctor's crisis. We are having a healthcare professional crisis. And this is something that is happening all around the world. So in many different countries, we are seeing that we have the highest number of healthcare professionals, but we are having a healthcare professional crisis. So I think this is the question we should be answering to. This framework is very fundamental for us, because it talks about retaining and recruit. It talks about optimizing performance, about building supply, and not just about starting the machine of creating physicians in order to have more and more and more. And the third thing is about the patient involvement in NHS decision. That is also related to the objective I was talking about recovering the NHS pride. I think that the legitimacy of public NHS should be worked upon above the participation and the involvement of patients, and I think, and the engagement, and I think this is something that we are trying to face. The second one about the health promotion equity-based approach. We have been trying to deal with, as you were seeing, tobacco and alcohol, and dietary issues are one of the top risks for health. We have been dealing with commercial determinants of health, with the lobbies, especially related to tobacco and to alcohol. We are trying to work also on HIV and sexually transmitted infections, as they are being increasing, especially in young population. But I think that I wanted also to talk about that here, because I think our job in HIV and SIT is an example of how to incorporate the social engagement and the social involvement in our structural committees in order to have a continuous contact with the civil society organizations in order to be able to give a rapid response when it's needed. For instance, when Mpox pandemic was again stated 1 year and a couple of months ago, we were able to work together with the group we had already been working together, and it was people working on the organization of people dealing with HIV, dealing with STIs, in order to make that the community and the the upstream policies were working together. And the third thing about the role of so climate change is also one of our top priorities. We are working in all the regulatory issues in order to arrive to be carbon neutral and National Health Service by 2050. There are already some hospitals that are close to arrive to be carbon neutral hospitals. We are working together with many other different ministries in order to this intersectorality to arrive to policies related to energetic transition, to transportation, to education, trying to put this public health perspective into all the climate change policies. And we are trying to work very specifically in everything related to drugs, as the low carbon emission drug development and production process are also a way of incentivizing the innovation, but also the implantation and implementation on local production factories in our countries. So I think that this is something we are working also a lot. On prevention, preparedness, and response is very obvious, but I think I wanted to outline the one in the middle, the open strategic autonomy. I think I don't know if you are familiar with this term. It's been like a top priority in Europe, and it's what in other fields and other regions it's called the health sovereignty. Mainly, when pandemic arrived, we saw that we could not be producing and manufacturing everything in China or in India or in too far away, that when public health emergencies are arriving, maybe the supply chains are going to be cut. So for us, it is a domestic priority that is aligned with the priority at the global level of increasing the capabilities of production of the many different regions. This one was about promoting the robust global health architecture, and we have been the Spanish government trying to increase the Spanish role in global institutions. In fact, our health minister joined the executive board of WHO after a couple of decades that nobody from Spain was being represented there, but also trying to develop a kind of leadership at the European level in topics related especially with sexual rights and gender equity. In a moment that Europe is moving to the right or even far right, I think that trying to champion, trying to lead in the defense on the work on social or sexual rights and also on gender equity in health is a top priority for us. And also performing this role of linking between Latin America and Caribbean and Europe that Spain has also always been having. And this last one, about the research and development and innovation, we have been approving a Spanish pharmaceutical industry strategy, sitting together to all the actors involved. We are working about a health technology assessment system, and also something that is very important, but I think, and I hope not, but maybe it's going to be affected, the transparency on drug financing and pricing. I think this could be really affected by the most favored nation clause that very recently Donald Trump was announcing here in the United States, and maybe it's going to have negative effects on the pricing, but also on the transparency on pricing in Europe. So to be finishing, I wanted to outline 2 or 3 slides. We have been talking about the global health and domestic health perspective and how they can be like overlapping or how they can be like giving feedback one to another. But I think there are these 4 things that I wanted to outline that I think that they are influencing both levels. The first one is that we are living in the polycrisis world. We have been the ecological crisis, social crisis, the care crisis, economic crisis. So this situation of living in an eternal crisis, I like to call it like a matryoshka crisis, that you know this Russian dolls, that when you think you have overcome, that you ended with a crisis, you arrive into another one, and it's going to be bigger. And so the biggest one, like the final boss, is the ecologic one. The other thing is about the lack of equity in healthcare response in times of crisis. So I think that something that really characterizes the times that we are living is that crisis is not a crisis anymore. So crisis is a structural characteristic of the world that we are living, because of the war, because of the natural disasters, because of climate change, because of economic or political crisis. And I think that when crises arrive, the better off tend to go their way. And they have a bigger capability to attract the public efforts. So I think the lack of equity in healthcare responses to this eternal crisis that we are having, I think is also one of the challenges we have. The third one will be the global competition for scarce resources. So Spain is competing with Argentina for the physicians, but Argentina is competing with Bolivia. And so this is like a change competition for scarce resources, and it's also going to be happening with drugs or with other material. And the fourth one is very obvious, is the crisis of multilateralism. Being very critical with how multilateralism has been working since Bretton Woods, we should be noticing that no multilateral organizations is quite worse than the existence of improvable or multilateral organizations that could be improved. And I think that this crisis of multilateralism is especially going to affect to the countries that don't have the same possibility to be sat on the same table as the other countries. So in the beginning, I was saying that when we are talking about the theories of justice, we should answer what are we going to distribute, who are we going to distribute that, and how we are going to do that. And I think that we are now in a situation that we know what should be done. So we know what we should distribute in order to arrive to a more equitable situation in terms of health and global health. We have a crisis of the who, and this crisis of the who is seen when we see, for instance, at a domestic level, how people from the margins of society are seeing how some rights are being removed from them. I'm talking especially, for instance, undocumented migrants in many countries. I live in Spain. My two neighbor countries have recently announced that they are going to increase the barriers for access for undocumented migrants in health, Portugal and France. And I think it's like a global trend that is also happening. And we are living the impotence of the how. So we think we know what do we have to distribute. We might arrive into an agreement about between whom we should to distribute that, but we are feeling the impotence of really making a change. And I wanted to finish with this one. I don't know if you know this document. This document was published 11 years ago. It was in the 2014. And one of the authors, Norman Daniels, one of the top public health philosophers in the world. And they developed the example with the famous WHO cube that I think is very useful to understand this difference between the what, the how, and the who, but also to understand that when we are talking about concrete policies, many situations we have to say no to some things because we should prioritize the other actions. This graphic is telling us, imagine we have like a concrete amount of funds, and we want to increase. We want to say, okay, what services are covered, but if you increase the amount of services covered, it should be done by decreasing the population who is covered or by increasing the cost sharing that population should be charged with. So this situation, I think that helps us to understand how in real life, we could say, how they interact, the services, the population, and the degree of the or the cost sharing for the population. So finish, I think this is the last one. Many times when politics talk, when I talk, I don't arrive to see me as a politician, sorry, when politicians talk, especially in academic fields. I think that we are expected to talk without, we could say, theoretical framework. And, but I think that it's very important to outline that in many times, and ideally, concrete policies are grounded, they are grounded by concrete theoretical framework, and this framework are also aligned, are also related. I was talking about which were the top priorities for our domestic health policies, and I was saying widening health systems, recovering NHS pride, and updating NHS to 21st century. But in fact, widening health system is quite somehow related to what are the services to include. Recovering NHS price is who should be including, but updating the NHS to 21st century is how are you going to make it possible. But also, the what is somehow related to redistribution, the who is somehow related to recognition, and the how is somehow related to representation. That are the three dimensions of justice that are classically studied, and I like especially how Nancy Fraser works on them. So I think that it's very important to say that in many situations, the political decisions are grounded on theoretical frameworks that are built on the things that from the academy are given to the social good, as a social good, in order to be built from the paper to the regulation, we could say. So nothing else, just to end, saying that, in my opinion, I think the top priority when talking about global health is that global health and domestic policies should not be disconnected, that global health has moved far away from assistantialism to a more complex political view, and that health systems should have an equitable approach and look beyond its own borders in order to be related to the other fields that they are going to interact in order to improve the health status of their population. So nothing else. Thank you very much.
Congratulations. I always monitor the screen to see how many people online have stayed with you till the end of your talk. No one left. So good for you. Congratulations, correct. I have a question. I think very diplomatically, you have not mentioned the economic perspective at the forefront of your studies. But I was in Barcelona a couple of years ago, and to my delight, as I was walking through the city, I encountered a strike by nurses. And one of them found out that I was a doctor, so he, in my broken Spanish, I asked why they were protesting and why they were going to strike. And obviously, her complaint was that they were not paid that. I'm not pointing the finger at Spain because it's a global issue and global issue around. I was very delighted about your vision for the role nursing is going to play in healthcare in the future. But the big question is that nurses are undercompensated. And that is everywhere. And is probably the better sign of what you consider the cascade of migration of physicians. It's actually worse for nurses.
Mhm.
They go to their countries to recruit. They don't even have to come here. Hospitals go to the Philippines from
Yep.
the United States on a regular basis to recruit nurses. So what is your answer about the economics of healthcare? And I think it ends up being also related to what you described as the pride in your national healthcare system. Obviously, the workers within the healthcare system need to be proud themselves how they are treated in order for that to translate to the system as well. I know this is a question that is not easy to respond to. But what is happening within the Spanish political system to work on this crisis?
In Spain in general, we have an issue with salaries in general. So we have, I think, one of the things about our economic structure is that our salaries are, in general, really low. Part of that is related to our economic structure, tourism, and everything related to restaurants, bar are low-paid jobs, and compared to pharma industry or biotech or something like that. But especially in the public health system, I think that maybe this public monopoly has had, from a salary point of view, some consequences in containing this inflation tension of the salaries itself. I think that when we compare it, because when we compare it to Europe, Spain is at the bottom of the salary scale for nurses, for physicians, for all the. The situation is that when we compare it internally to the different professions with a similar degree of instruction, we are above. So I think I was in one of these reports, Health in Transition, the country profile. I think it was 1.8 for physicians and 1.5 for nurses, compared to the similar level of instruction. The thing is that we have been seeing that increasing salary, for instance, I'm talking to maybe the field I know the most, because I have been working there, but also because I think that now it's like the most important one, primary care. I'm a primary care physician. And in primary care, we have been seeing that increasing the salaries is not enough for retaining our professionals. In many times, all the policies and the interventions related to the mix and the possibility to be available, the personal and the working life, so the flexibility in the working times that they have, the possibility of working near their home, and everything related to professional career are also having a very big impact. So the situation is, because when we are talking about the increase of salaries, we should think, when do salaries increase? I think that there are only, in general, two situations where salaries increase, and they are not increasing the salaries in the same way. One of these situations is social conflict. So, in general, all the working struggle in order to increase the salaries have been through strikes. So this is the one. The other one, and this is not, we could say, institution or enterprise driven. So I think this is most influenced by the workers. The other one is scarce. So when we don't have these workers, the thing is that this is not a symmetric increase. It's going to be specifically directed to certain points. And in systems that are, in general, not generating competition between different fields and that are very big, hugely egalitarian, I think this way doesn't happen as much as it should have. And when we do that, in many situations, it's seen as we are trying to copy the enterprise way of functioning and incentivizing on salaries. So I don't know how it's going to end. Well, in the last years, especially after the pandemic, for instance, in Spain, there has been an increase in the salaries, especially of physicians. I think that when you go to the news and when you go to the media, there is the inverse care law of Julian Tudor Hart, we were saying in the beginning. It's also quite the same when we are talking about the importance of the salaries in the media. So the better paid have a bigger capability of appearing in the media talking about the need of increasing their salaries, but we don't tend to be paying attention to the income gap that we have in our services. We in Spain we have a huge income gap between the nurse assistants compared to the specialist doctors. No, so I think this is well, in fact, the biggest amount of money that we are spending is not on drugs, it's especially in the people that are working. So it's in the professional, it's in the salaries. But I don't know how it's going to be. I think it's going to be increased because it's happening. But I don't know, especially how it's going to affect this global chain of healthcare professionals. So we don't, in Spain, we don't go to any country to recruit professionals. But we have an incredible recruitment of professionals, but it's not because we are doing special efforts of doing that. But the salaries and the working conditions and the professional career is an issue on that. We do see professionals from Spain going to other places by the salaries. At the European level, I think it's Ireland and Scandinavian countries, the two that compared to Spain are paying the most. And nurses and physicians, both, and physicians, both. I am all the Tuesdays, and personal anecdote, all the Tuesdays I have 1 hour of English lesson, and my teacher, he's from Canada, and I think that repeatedly, he asked me about the physician salary because he's very surprised about the low salary the physicians have in Spain, because he has a couple of colleagues in Canada that they are top salaries compared to a Spanish one. But when we go to the other day I was Googling and showing him that when we go to our domestic salary scale, an average physician that has been working for 20 years, so he's in the middle, we could say, of his career, is in the 97th percentile of income. The problem we have, especially, is in the first decade of professional career, and very specifically in the first 5 years of professional career. We are the second at the bottom in the European Union scale of the salaries in the junior doctors, and we are on the average when we are talking about senior doctors. So there are also inequalities inside our professional structure.
Thanks so much for taking the time to join us. I guess you could tell your Canadian English teacher that at least they don't have any debt because school is free in Spain. Money here, but you mentioned in your nice overview the commercial determinants of health. Next week here at CUNY, we'll have a meeting to discuss that with some experts in the house. And I'm just wondering, how is Spain addressing this? Because I think more and more we talk a lot about social determinants of health, but there's all of these independent pressures. And I know that you mentioned alcohol as a leading risk factor of morbidity and mortality. And I think your taxes on certain alcoholic products are lower than they are on many other products. So Spain recognizes this. You recognize the contribution of alcohol. You recognize the commercial determinants of health. But what have you been able to do anything with that? A couple of days ago, and sugar tax. Very interesting and landmark. What is Spain doing?
Well, last year, the last period, the previous 4 years, it was established an increase in the sugar sweetened beverage. In my opinion, it was not like technically, it was not like the ideal way of increasing because it was an increase on the value added tax, but it was not an excise tax. But I think it was a good one. And now we are currently working very specifically on tobacco, and we are facing, we could say, like huge efforts from the tobacco industry trying to stop that. In fact, we have been facing how many different countries influenced by tobacco industry have been like raising some concerns at the European level about our new regulation to prohibit the flavors on the e-cigarettes, on to limit to a very small concentration the nicotine bags. I think the other day, Robert Kennedy in the appealing in the Senate, he was having a nicotine bag, and that is not very common in Spain, but it's very common in many other countries, especially the Scandinavian countries. And now it's arriving to Spain. So we had a quite an attractive, quite an advanced regulation a decade ago, but now we should really update the tobacco regulation. But we were talking about alcohol. In Spain, we have an issue with alcohol, and we have a cultural issue with alcohol. We were talking about that during the meal. We have a law about tobacco, and the tobacco law in Spain is against tobacco, but the wine law in Spain is in favor of wine. I think that's a very good example of how things work. And the thing is that there are regions where culturally and economically the weight of alcohol industry is very big. I don't know, many of you know, if I say La Rioja, it's a wine production region, and it's very, very important. So when we talk about alcohol in Spain, in general, it's not the health ministry who talk about tobacco. It's the agriculture ministry that in general is going to protect the development of the wine industry, for instance. The thing is, what approach are we trying to have in order to be able to tackle the alcohol situation in Spain, even though we know it's almost something that could not be even discussed. We have approved a law that should be approved in the Congress, in the Parliament. It's called the Law for the Prevention and Control of Consumption of Alcoholic Beverage in under 18-year-old people. So we found that teenagers were the population where we had the social support to face a regulation that is going to have probably not only economic, because I don't think that the economic impact is going to be the biggest one, a cultural impact. We are going to act on advertisements, we are going to act, and we want to act on the possibility of trying to sell the theoretically that are false values, positive values of alcoholic beverage for health or for well-being or for whatever. But tackling infanthood, we are trying to act on the general population and on the cultural and the alcohol promoting environment of alcoholic beverage. And so I think that the most important intervention would be the same that we did the last year for tobacco, increasing the prices. So Spain is now the place where many other countries go in order to drink cheap. And in Spanish, when they go to a foreign country and they say that they are dosifying the shots, they don't believe that, because in Spain it's like, okay, give me more. So, and we have a problem with prices. So the thing is that the window of opportunity we have found at the moment has been by trying to act on infanthood. I think that after that, if we get to pass the law through the Congress, maybe we should be like step by step working on that. For instance, I think it's a very good example in Spain, in Madrid, the region of Madrid, you know, the capital city, 7 million of inhabitants. There is a regional strategy for drugs and addictions. The word alcohol doesn't appear. Neither tobacco. So the top most consumed drugs in Spain that don't appear in the regional strategy on drugs and addictions. And I think it's, well, it's obviously a problem, but well, we already passed through the Congress the first law in our history that goes to prevent and to act on the consumption on alcohol. I should outline that many years ago, there was a health minister that tried to pass a law that it was called La Ley del Vino, the law on wine, and she was dismissed. And it was because of the pressure, and it was said to be because of the pressure of the alcohol industry that has quite a big impact. Elena Salgado. She was candidating also to be a general director for WHO, and she get to the last three now, or say to the final. So, but she there, and that was the thing.
So you want to increase the price of wine and not increase the salaries?
No mercy, yeah. Which one? The NHS in Spain is predicated on the principle of health promotion and the equity-based approach. What are the guardrails, whether legislative or constitutional, to protect this approach against a potential pushback from opposition groups who may eventually be voted into office and change the paradigm? Yeah, this is something that I think that we always, when someone is in the position I am now, one of the things one wants to do is not just do things, is do things which are going to be living after I am going away from here. So the thing is that in a democratic system, everything we do can be undone. The thing is how we win the cultural battle in terms that it cannot be dismantled. For instance, the 4 years ago, we approved the law on euthanasia and dying-assisted suicide. When in fact, it's euthanasia. We know there is a possibility that, depending on the changes in the government, it can be undone. The thing is that it was done with an incredible popular support, even in the right-wing parties that were voting against this regulation. It was approved, it was implemented, and no one has ever talked about that. Sometimes there is a judge that says something, but there are anecdotes. So the thing is that I think that we should not be afraid of tackling these maybe complicated debates. For instance, we are now in a situation in Europe where talking about universal health coverage, especially for undocumented migrants in many countries, is not like a winning option from a political point of view. But I think it's the only option from a political point of view, being in the government as we are. And now we are working not just on a law that we don't know if it will be approved in the parliament, but also in a royal decree that doesn't need to go to the parliament, to have some things related to trying to create a structure that, to be dismantled, should be like more difficult. It can say that, well, this health promotion and equity-based approach is going to survive ourselves and is going to be able to be developed by another group of political parties that are against this. The thing is, in democracy, we cannot say that. And this is not, we do not write in stone these things by stating in laws. We write in stone these things by winning the social consensus. I think another place, another topic where we think that this consensus was achieved is everything relating to abortion. I think abortion is going to be opposed if we have a change of government, depending on the different balances. But I think it's going to be opposed in some ways. But I think that if they try to change the regulation we have now to another more restrictive, the situation in the streets is going to be really incredible. And because people is not going to go away from this right that we have, that we gain. It's true that in many other things it's more difficult. For instance, we know that that primary healthcare is going to increase your life, to decrease the number of diseases, to increase the number of lives you are going to be living without disabilities and so on. But dismantling primary healthcare is not just a one intervention shot. So it's easier to, for instance, delinking your doctor from the concrete patients they are saying. So you are going to see whatever you are going to say. So it's easier to break with the relational continuity of care or these main values. But things like abortion, euthanasia, and so on, I think they are like, one-shot rights that are much more difficult to dismantle. Like? Yeah.
Sure. Data that Spain was leading in life expectancy, but trailing in the proportion of elderly with multiple systemic diseases. And I was wondering if those are just flip sides of the same success of the national health system in allowing people with multiple chronic conditions to live longer. And on the other side, if it was dismantled and there was no healthcare system, you would have a low life expectancy, but no one would be.
Yeah, but then you take a look to Sweden, for instance, and they are top performers in both for instance, indicators. I think, and this is a very particular hypothesis, I think this is the effect of a family-based society in a context of patriarchy. Because what we are seeing is a big inequality in the number of years without disease in between women and men, that if you analyze these graphics, what you are saying is that women are living a lot of years with health issues, and maybe these health issues are because they are taking care of other people who have health issues. So I don't know if in a social structure like Spain, Italy, and Greece, that is maybe quite similar, familiar ones, they are the same. They have the same issues. High performers, one better than others in the life expectancy, not so top performers in the healthy life expectancy, and the three are the same. And I think that the thing that they share is not the great health system, because, for instance, in Greece, I think it's not the situation. I think it is the family structure, society, that makes that people, women, care for the others, and these years they gain are years they are, putting in their bags and in their baggage, and they are carrying with them. But it's not. It's my hypothesis.
Thank you so much for your talk. I'm really interested in that element you talked about in terms of goals for recuperating pride in the national health system. And in particular, in this country, we don't have a national health system. We do have public health care that's basically based on low income and poverty, and it's incredibly stigmatized. It is a political issue all the time. And so in a country like Spain that has a national health system, is it about, so for one thing, is the pride the individuals within the system? Is it both like the professionals in the system as well as the population using the system? Aside from my thoughts that maybe everybody's going to have complaints, right? Like they feel they could get better care or they have to wait too long. Aside from that, is there something different in terms of this, desire to increase pride in it? Might it be that it is this value that Spain has that in comparison to other countries, the population might do well to understand that the Spanish population does better potentially in certain health indicators? Is it a communication issue? Then people would just be naturally a little more, have more pride in it. I'm just curious because here, it is a political issue, and what we do have is incredibly viewed in a negative way.
I think that in Spain, when you ask people what is Spain good at, they are going to say our public health care system. And I think that this is something very difficult to build, and it's very easy to do, to remove or to waste. I think that one of the things that we are building on this kind of pride is mainly the universalism. And okay. Wow, repeating this question is not so easy. Okay, how do I repeat the question? Maybe she was telling about this pride of our national health system, how it is built, and if all the people using that, and not only the worse off, but also the better the better off, and if it's grounded on the system itself, on also on the communication, on other kind of intervention related to that. And I think that merging this explanation with the answer, I think it's okay as a whole landscape. So I think that in Spain, one of the best things is that it's universal, but it's actually universal. So if you ask people if they have a serious, severe health issue, where they go, people, I think it was like 95%, they say, to a public provider. So I think that this is like a kind of guarantee that the social perception of the provider and the system is that it's going to solve their problems when in the situation that they are most vulnerable. So I think this is something very, very important. And I think the most important is that it is the same in the better off than in the worse off. I think it was in 2012 that Martin McKee and David Stagler published a paper on the British Medical Journal called The Assault on Universalism, How to Destroy the National Health Service, or something like that. And one of the things they said was that the first step was to identify like a group of people that should be seen socially as they don't deserve the access to health. But the second thing was making the better off, making the people with the highest income to feel that they are not receiving the nothing for the money they are putting to finance the health system. And there were some more steps. I think, and when I talk about universality and universal health coverage, I say it very frequently, universal health coverage is not something for undocumented migrants or for people under a certain income. Universal health coverage is to say that these people are going to have the same providers than the CEO of a digital company. And I think that this is the legitimacy of our system. And this is the thing that make us proud of. And in many situations, when we see that, I don't know, when that someone very well known, an actor or someone quite famous, goes to a public hospital, I think this is something that also should be, you know, it's the best advertisement campaign that we could have. Some years ago, it was very famous. We had Michael Robinson. He was a TV presenter. I don't know how you say that, but a TV host of a show, and he was also a former football player. He had a skin cancer, and he went to a private company, and they were treating him. And when he arrived to a certain situation, he was said that he should go to a public provider because he was not going to be able to have the treatment he needed. He went, but he made it public this situation. So it was a representation that when you are struggling with something, you have your national health system. We all pay them with our taxes in general, and we all receive when we need whatever we need. And I think that the fragmentation of the system and the different, the different providers, depending on the incomes and so, breaks the possibility of thinking the health system as a whole. That is, you cannot be proud of your 10 different providers that you have. No, you have one thing, it's national health system. It doesn't matter if you have one different in each autonomous region, or I don't know, I think the United Kingdom is like the extreme example. Now in Spain, we are starting to finance a part of the glasses for the kids under 16. But it was said that when they started to do that in the United Kingdom, they the glasses they were giving to the people, it was the logo of the National Health Service was on the glass. It's, you know, if we did that, we could be, well, we would be told we are communists and so on, you know. But well, okay, things change. Okay.
Doralee, do you want to ask your question?
Hi, good afternoon. Yes, I did want to ask a question. Thank you so much for your talk. I found it very informative. But I wanted to build on the point that you had mentioned about women living longer, but those years that they are living longer, they are living with chronic illnesses and other disease that are going to impact their quality of life. Because I do remember reading an article, not a scholarly article, just like in the newspaper. I think it was like early 2021 that there was a growing generation of American women that felt like they were sandwiched between caregiver for both young children and their aging parents, and that they were feeling quite suffocated with that. And in my professional capacity, I do speak to a lot of these women who are caring for children still in school and also their parents, and find that they can't care for themselves. And so they let their own problems linger unattended for a long time. Um, so I do think that that speaks to a more to your point about a global universalism. I do think that speaks to the global idea that women are the people in families, in communities that are taking upon this work that could be done by a paid nurse or some other professional capacity.
Yeah, and I could add that even if it's done by a professional caregiver, there is a sexual division of work that would make that the impact of these care jobs would impact more and in the women than on men. No? I think that the dynamics of the life expectancy gap between men and women is going to change in the next decades. There are some prospections very clear about that, about how this gap is closing, and it's not closing because the men are going up. It's closing because the women are going down, and they are going down especially because they are being incorporating to some of the situation that made that men were dying before. Some of them are related to some consumptions, tobacco, alcohol, but many others are related to the economic conditions they are living. You were saying that this generation that is living between caregiving the elder and the younger. I want to add another situation that I think it's also having a big impact in in a concrete group of population, and is the population who left their kids in their country and are caring for the parents of other families in other countries. So I think this situation is quite stressful and has really an impact on health. And this is a part of what is called like the global change of caregiving. And I think it's also a situation that is very concrete for women. I think that in men doesn't really happen at the same situation. But yes, I think that these dynamics of the difference between lifespan and healthy lifespan and the relationship with the sexual division of work, we could say paid work, but also unpaid work, is at the core of something that is so important for public health. That is how many years people live and how do they live that.
coming to CUNY. I appreciate your sensitivity to the source of your healthcare workers globally. And I see why you have so many people coming to Spain, given the common language with many countries. My question is whether in this situation where political and governmental choices in the United States have made the United States a less attractive place for global students or workers to come currently, whether your government is trying to benefit or capitalize on this situation. For example, I have heard a lot of information about French programs to bring in those either from the States or those who would usually be coming to the States. And I'm curious whether you look at this or if, given you said you have a high number of healthcare workers already, this is not needed.
I'm going to repeat to summarize the question. It's about the situation in which the current situation in the United States makes it might be a less appealing place to come for professionals, but also for people from the research field and so on, the universities, and if in Spain we are doing any intervention, any action in order to recruit some of the people who are in this situation here. I think this is, unfortunately, this is a reality, and I think that all the countries in, well, all over the world, but especially in Europe, we are facing some interventions in order just to try to recruit. The thing is that in Spain, in the previous decades, we had been seeing how many Spanish people were coming to the US to develop their professional careers, healthcare professionals, but also in the academia and many. So what we are trying to do is, to facilitate their return to our country. We have been having some meeting with some organizations of Spanish, for instance, Spanish physicians working in the United States and trying to see how it would be possible to facilitate the, the homologation or the identifying, the validation of the training here and there. It's not very easy in many situations, but we are trying to see how to do that. And I think that it's a reality. So we are not trying to, to compete by the top scientists, and we are trying to make that people who were instructing in our country and that they might be willing to go back, they come back. Everything within a European perspective.
This is interesting because I understand Italy is doing something similar and trying to bring Italians abroad back home, whether they are medical or software engineers, anything like this.
Yeah, I think that, well, in general, in the professions that are said to be like we have more, that the scarce is bigger, we tend to increase our efforts to facilitate this kind of return. Yeah.
Interesting. Thank you.
Thank you. Thank you to the people on the other side.
Thank you very much. Thank you so much for this input.